Hello everyone, thanks for joining us today. I'm Cheryl Lai, Senior Editor of the Lancet Oncology, and on behalf of the Lancet Oncology and the Lancet Group, I'm delighted to welcome you to this Lancet webinar on the Lancet Oncology Commission on Radiotherapy and Theranostics, which we're hosting in partnership with London Global Cancer Week. Now, before we get started, I'd like to go through a few housekeeping points. Please feel free to submit any questions for our speakers using the question box on the dashboard. There is a related resources box, which includes content related to this webinar, including the Commission report, all available at thelancet.com. The Commission is free to access with registration until the end of November. You can adjust the dashboard for this webinar to suit your preferences. A link to the on-demand version of this webinar will be sent out after the end of the session. And once the webinar has ended, I invite you to answer our 30-second feedback survey to help us improve our future webinars. Now, I'll be handing over to my co-chair to introduce the speakers in a few moments, but first I'd like to mention a slight change in the programme. Sadly, Dr. Elena Fedorova is not able to join us today due to unforeseen circumstances. Unfortunately, we have an outstanding group of speakers who are able to join us today. So it gives me great pleasure to introduce to you my co-chair for the session, Professor Mary Gospodarovich. Mary is Professor of Radiation Oncology at the University of Toronto in Canada. She was previously Director of the Princess Margaret Cancer Centre in Toronto, and also she was the Regional Vice President of Cancer Care Ontario. She has extensive experience working on clinical trials of radiotherapy, image-guided radiotherapy, cancer staging and prognosis, and cancer survivorship. And her current interests are in global cancer control, global access to radiotherapy, and quality cancer care. She is an author of our recently published Lancet Oncology Commission on Radiotherapy and Theranostics, and she also chairs the Lancet Commission on Cancer and Health Systems and the Lancet Oncology Commission on Cancer in the Commonwealth. So thanks so much for joining me as co-chair for this webinar, Mary. Over to you.
Thank you very much, Cheryl. It's a great pleasure for me to co-chair this session, and it was a great honor and privilege to participate in the Lancet Oncology Commission on Radiotherapy and Theranostics. As Cheryl said, almost 10 years ago now, 9 years ago to be precise, we published the first Lancet Oncology Commission on expanding the access to radiotherapy globally, pointing out to the fact that there were huge disparities in access across the world and huge deficiencies both in physical resources, such as radiotherapy equipment, and human resources around the world. When you publish the Lancet Commission, you hope that people will take notice and you hope to stimulate action. And indeed, having recently had a chat with May Abdel Wahab, we noted that the conversation about access to radiotherapy globally has expanded over the last 10 years. It's no longer a secret. And there are a number of initiatives that are directed to correct the problem. So it's been fantastic to see the second Lancet Oncology Commission on Radiotherapy, and this time including access to theranostics, being published. So today we have for you a number of superbly qualified prominent speakers that would walk you through the findings of the Lancet Oncology Commission. They're here from all over the world. This session is a bit of an experiment. Not only we're virtual, but we have a mixture of pre-recorded and live sessions. But as Cheryl said, you will have opportunity to ask questions, and we have people live online to answer them. So just to introduce, First and foremost, May Abdul-Wahab, who is a Director of Human Health in IAEA, a radiation oncologist, and a recent Astro Gold Medal winner for 2024, who has been the really backbone and the fearless leader behind this commission. With her is Andrew Scott, who co-chaired the commission. Andrew is a nuclear medicine leader from Australia, has made enormous contributions not only to nuclear medicine, but to theranostics and now to this commission. With them, there's Mauro Carrara, a medical physicist who is working in IAEA. Diana Paez Gutierrez, also from IAEA, nuclear medicine physician. Francesco Gemarile, who is going to be talking about nuclear medicine, as we heard. Unfortunately, Elena Fiderova is not with us. So with that, I think we're going to go briefly through the agenda. Following this brief introduction, we'll hear presentation of the Commission of the report given by May Abdul-Wahab on the radiotherapy aspects, Commission report on theranostics and nuclear medicine from Andrew Scott. And then we'll hand over to Mauro and Diana to introduce submitted shared perspective on the impact from number of international organizations and the thought leaders from around the world, which will be followed then by presentation of Francesco, who will introduce the further presentations on the implementation of Commission findings. So this will probably take about an hour, and then we'll have some time for Q&A, and I'll try to do the best I can to coordinate the Q&A session with Cheryl. I'm in Toronto, Cheryl is in London, so through the miracles of modern technology, we'll hopefully have a sort of well-coordinated Q&A session with you. Thank you. So I'll hand over to May.
Thank you very much. I think you can hear me well. I just, first, before presenting the report, I just wanted to thank London Global Cancer Week organizers and Lancet Oncology Commission editors, especially Cheryl, of course, and David, and to Mary for moderating, and to all our collaborators and commissioners. So as you may recall, there were two Lancet Commission reports that were published previously, one in 2015, that was the Lancet Oncology Commission on expanding global access to radiotherapy that Mary mentioned, and the other was the Medical Imaging and Nuclear Medicine one, published in 2021. Both of them serve as a cornerstone for this commission in terms of the next steps. So the goals of this commission was basically to analyze access to radiotherapy. That included infrastructure and training, and also the technological gaps because of the advances in radiotherapy that have occurred since then, and the increased spread of the use of theranostics. So all of these are new areas that we wanted to address. But we also wanted to say these calls of action that were called during the last Radiotherapy Commission, what has happened and how did we do? And also to look at issues related to theranostics that I won't get into too much because my colleague Andrew will mention that, especially access and production. So we had some action points, of course. Now, it's important to note and thank all the authors. We had 52 authors, 44 institutions, 23 countries that were involved, and you can see the professional groups that supported this effort. And inside the Commission's report, we had different areas that we covered, as I said before, some on radiotherapy, theranostics, optimizing resources, hypofractionation, we'll talk about that, access to theranostics, safety, quality, and research and innovation, and so forth. So there were many areas, but it's really important to note that we did come up with a call to action. And that hopefully will, in a few years, we'll be able to see whether we were able to do what we wanted to do. So for this particular presentation, I'll talk about hypofractionation specifically as a way of resource sparing and the availability of radiotherapy machines and access and workforce. So if we take prostate cancer and breast cancer as examples, we start with prostate cancer, and we'll see that it's an estimated total of about 3 million patients with cancer, prostate or breast, that would need radiotherapy. About 0.9 million with prostate cancer around the world, and about 2.1 million with breast cancer. So the need is quite significant, and the pressure for access and use of machines is also significant. So one thing we looked at is hypofractionation and whether that could help in terms of access in these very common tumors. And we found that with conventional radiotherapy, we would need 33 million fractions to treat the prostate cancers that need to be treated, and 52 million for the breast cancer patients. But if we did hypofractionation, we could only need 18 million fractions for prostate and 30 million fractions for breast cancer. So why does that even matter? Well, it means that this would be an additional 2.2 million patients that we could treat with the same machines and everything. So what about the economic situation? Is there any impact on that? Well, if we substitute conventional radiotherapy, the longer courses of treatment, 50% of the time, just 50% of the time, we would get a potential cost savings of 1.28 billion in prostate cancer and 1.48 billion in breast cancer, with the same equipment, without investing in anything extra. And we're using moderate hypofractionation so that we would be able to not have, let's say, more costly equipment and techniques that we would have to use. If we substituted it 80% of the time, this could grow to 2 billion and 2.37 billion. So there's a significant cost benefit to doing it as well. But then we wanted to look at SBRT. And the reason for stereotactic body radiotherapy is that it's a more complex radiation technique. And we wanted to compare it to conventional radiotherapy in low middle income countries. So that is quite an ambitious goal, as you can imagine. And basically, it was shown that if you do SBRT, the cost would be about 11,000, and is more cost effective than conventional, which is 13,000 over the life of the patient. So even though the initial course may be more expensive, but over the life of the patient, there was cost effectiveness, and the quality score was 2.8. So it was 1.99 for the conventional. So this was interesting, and the first time that to show in LMIC, and this was an example in lung cancer, that there was a significant benefit to using SBRT in these patients. So what about the availability of these machines, and why are we talking about hypofractionation and so forth? Well, if you look at the global availability of machines, you can see very clearly there's a disparity between high income and low middle income countries, which is expected. So if we look at high income countries, most have the 5 radiotherapy machines per 1 million inhabitants that we quote, and that usually reflects into timely access to radiotherapy. Of course, there are other factors like geography, insurance, and other things like that. But then if you look at other areas, the figure dramatically drops, right? So here we looked at, among all income groups, we looked at the clear gap in LMICs that is higher for countries with fewer resources. And we looked at the imbalance. The dotted line, you can see the standard 1 machine per 500. And you can see that in most countries, we're heading and inching towards that goal. So we're doing better. However, there's still significant gaps between the countries. And for high income countries, it's gone down slightly because it's starting to go towards the recommended number. So then if we look at regions and income groups, we can look at here the distribution of machines per region, and we can see a significant difference. And we'll notice that North America has the highest proportion of radiotherapy machines per patient, And then you have, of course, sub-Saharan Africa with the lowest proportion and so forth. So it is region dependent. So it's important to have a machine that's working, available, and that the patient can continue treatment without any downtime. And this results in significant interruptions, result in less control of the cancer. So this is very significant clinically as well. So looking at 28 African countries, we saw that the average downtime here is shown, and it's different even within the same continent from region to region. And we can see that, for example, for Central Eastern Africa, reporting more than 20% average downtime of their machines. And we wanted to look at also, okay, so there's a difference in downtime. What are the factors that can predict this? So the machine downtime, there are many factors, as one could imagine, whether there's on-site access, availability of staff who could repair the parts, and availability of funds for maintenance. But the biggest major reason for downtime was insufficient access to spare parts. That's very interesting. A lot of times we'll quote the power issues and other things, but spare parts is something that we should be able to address. Then what we want to say is, like, we have one machine per 500 patients requiring. If we have low-income countries, we would need to increase the machines by a factor of 8. So that with that, you can see how important it is to do things better with what we have, as well as buy more machines and train more people. So training more people, what about the workforce? Well, unfortunately, workforce is a big issue. We just had another session with the IEA, WHO, and IARC in this London Global Cancer Week. And workforce issues are critical now, and there's a crisis that's going on in workforce. So having said that, if we look ahead to 2050, the projected surge in cancer cases would require the current workforce, to be expanded by 60%. So we have a lot of challenges, and because of that, we need to work together towards changing the reality on the ground. So here we have a call to action through the Lancet Commission report, and we looked at optimizing this use of resources. We put it as action 1, and you can see why, because the demands are so great. We need to continue to make sure that we're able to fill in the gaps and increase access for our patients. We also need to align human resources. That was the second action, because as I said, workforce is critical at this point and is undergoing a crisis for many reasons we won't get into right now. But human resources have to be also aligned with the patient needs and make sure that we're able to deploy this additional capacity better by innovation and education and training and many other areas, and policies, of course. Then we want to have global standards for infrastructure and optimal deployment of advanced radiotherapy and theranostic services, 2 areas that we looked at extensively in this particular commission. We want to ensure the global availability of radioisotopes. And as many of you are aware of some of the challenges that we've had even recently with technetium-99. And of course, during COVID, it was a significant challenge with decrease in all of these studies that were being done because of access to these radionuclides. So this is a very important part. We want to be able to have a way to support clinical trials, not only in radiotherapy, but also in theranostics. And it's very important to note that the funding for radiotherapy, for example, is extremely low. It could be as low as 5% in one of the major cancer institutes that's funding these trials. And we don't get as much money coming from other, like private sector and so forth. So, it's an area of high concern. Then regulatory infrastructure is the basis of everything, safe and effective delivery. Money, we put it as 7 because while it's very important, there are things that are done that can be resource sparing. And so innovative financial solutions that don't create as much financial toxicity to patients or to countries, And there is a new report from the World Bank that shows the impact of various loans and things like that on countries. And then finally, collaborate and coordinate, and that's extremely important. One example is what's happening now with the Rays of Hope initiative. The only way to do it is to do it together. So this slide is not very clear. I don't know if anybody can see it, the very last slide, but that's okay. So basically, in conclusion, we want to talk about access to high quality care, that it's limited worldwide, and that we do have an outline now to see how we can support care that patients need, and to offer our healthcare practitioners, physicians, policymakers, evidence-based foundation. And I think that is the most important thing that comes out of these commissions. And with that, I thank you very much and hand over back to the moderator.
Andrew?
Yes, I think it's a recorded presentation.
Can we have Andrew's presentation, please?
While we're waiting for that,
My name is Andrew Scott, and I'll be presenting on the theranostic results from our Lancet Oncology Commission on radiotherapy and theranostics. So theranostics involves both imaging and therapy with radionuclides and radiopharmaceuticals. The imaging allows us to actually identify the target expression, which can then, if confirmed, result in the administration of radioisotopes or radiopharmaceuticals for therapy, either through intravenous injection, usually, or with oral administration in the case of iodine-131. And of course, follow-up is then important to be performed with standard CT or MRI or with PET and SPECT, depending on the clinical scenario. So in this context, theranostics is markedly increasing in its use, but availability is really at a global level not well known, and the key issues impacting on theranostics have not been fully assessed at a global level. So as part of our Lancet Oncology Commission on radiotherapy and theranostics, we assessed through a survey the access and availability of radioisotopes and radiopharmaceuticals. We performed a global survey, and through analysis of a database at the IEA from 166 countries, was able to establish the current use of theranostic treatments in all of those countries and the factors impacting on availability of treatment. We also undertook a detailed analysis of socioeconomic benefits of lutetium PSMA therapy, looked at workforce and training issues and research and innovation, leading to the calls to action, which my colleague May has also presented in the prior presentation. When looking at the source of radioisotopes, which are used for theranostics, reactors are the primary source of molybdenum-99, which is used for technetium-99M generators, but also for the beta emitters, the iodine-131, lutetium-177, terbium-149. And you can see from this slide that although there are quite a number of potential reactors globally that can make radioisotopes, there's only 4 that actually have large capacity in Australia, Belgium, Netherlands, and South Africa, with 5 with medium capacity, and a number that are really supplying just local countries. This does provide an issue of capability, particularly amongst the beta-emitting isotopes, which I'll touch on a bit later. From a cyclotron perspective, you can see here the total number within Asia, Europe, and North America is quite high, but in Central and South America and Africa and in Oceania, the numbers are quite low. Cyclotrons are used for the production of the PET short-lived radioisotopes, which are essential for some of the target validation studies and response assessment. These are, as I said, the areas where potential increase in cyclotron numbers will be necessary. And of course, when looking at cyclotrons per continent, you can see there is a marked reduction, particularly within Latin America and Africa, based on their population. Through our global survey, we were able to look at the common used theranostic treatments. Radioiodine has been used for well over 70 to 80 years for the treatment of hypothyroidism and thyroid cancer. And you can see that there is broad use around the world, certainly from countries where information was available. And the darker green colours indicate the higher annual use per million population. Clearly in Africa, some parts of Asia, there is less use, but otherwise quite widely distributed. This is quite in comparison to the use of radiopharmaceuticals for bone pain, principally in the context of prostate cancer and in breast cancer in some countries. And you can see here the use is very, very restricted to mainly North America and parts of Europe, with much less use elsewhere. Radioiodine linked to MIBG and lutetium dotatate in neuroendocrine cancer patients is also used quite extensively in Western European countries and in the US. But again, you can see that in Latin America, Africa, and in Asia, there is a very small amount of use despite the relevant incidence of these cancers in those countries. And then moving to prostate cancer, which is one of the areas of marked increase use and evidence for theranostic treatment, particularly lutetium PSMA, you can see based on numbers of treatments per million population, interestingly, North America and parts of Europe show reasonable numbers. In Australia, the high numbers are mainly because of the clinical trials which are being conducted. But again, Latin America, Africa, and Asia show a marked reduction in the current use of both the beta-emitting lutetium PSMA as well as the actinium-225 PSMA, which is mainly in trials. We then undertook an analysis as part of our Lancet Oncology Commission on what the projected need for lutetium PSMA would be based on the approved indication in the US and in some countries in Europe from the VISION trial and also the therapy study, recognising the differences in incidence of metastatic disease in prostate cancer patients of 18% in high income versus 43% in low income and middle income, Globocan numbers on prevalence, and also the clinical indication in the metastatic castrate-resistant prostate cancer population. And then we can compare this particular map to this map of what the projected need for lutetium PSMA in prostate cancer is purely on the basis of incidence at the moment. There was a Lancet Commission of prostate cancer earlier this year which suggested that the incidence of prostate cancer would double over the next 5 to 10 years. The calculations of numbers of doses and patients is shown at the bottom of the slide, where over 150,000 patients per year would be eligible for lutetium PSMA treatment, with over 550,000 doses required. And the current global capacity for lutetium production has been calculated as only sufficient for that number of patients. So clearly increased availability of the radioisotopes will be an essential part for theranostic implementation moving forward. When looking at the socioeconomic impact of lutetium PSMA therapy, we performed the modelling for 9 countries where the cost of lutetium PSMA treatment was obtained, as well as other treatment-related costs for the inpatient stays in relevant countries, although not all countries require inpatient stay. And then the foregone social impact when looking at the number of patients that are being treated versus which could be treated on the basis of prevalence of metastatic disease. We were able to demonstrate over $725 million could be saved over a 7-year period just in these 9 countries. And clearly extrapolating to a global level would increase to many billions of dollars for potential savings. When looking at the ratio of cost of treatment to GDP per capita, this is obviously based on both the cost of treatment as well as the GDP of the country. And you can see quite a marked difference between some countries where there is not just a high GDP, but also lower cost of treatment compared to mainly countries with low middle income country status and low GDPs. But again, this is the same issue which is needing to be addressed for any type of cancer therapy. And lutetium PSMA therapy has been shown to be efficacious and improve quality of life in these prostate cancer patients. When looking at workforce, we saw trends clearly where in North America, parts of Asia, Australia, and Western Europe, the numbers of nuclear medicine physicians were considered reasonable, although even in those countries it's felt there are deficiencies in numbers. Whereas in Latin America, Africa, and Asia, markedly reduced numbers. This is similarly seen for nuclear medicine technologists, radiochemists and radiopharmacists who are critical to the delivery of theranostic treatments, and also medical physicists who, for both radiotherapy and for theranostics, are essential for assessment of safety, dose, and appropriate patient care. As part of our commission, we've also looked at specific requirements for training of nuclear medicine specialists in theranostics. A paper has been published providing these guiding principles. It's clear that the training and education will be a critical part of improving the quality of care, as well as training increased numbers of workforce for the delivery of theranostics. Our commission established that the key factors impacting on theranostics availability were, firstly, as mentioned, the access and availability of radioisotopes and radiopharmaceuticals, available workforce, as you've seen from the world maps. Infrastructure for theranostic treatments is very important because of the regulatory requirements, and also funding for patient treatment. Additional considerations will include, in many countries, having an appropriate framework for regulations to allow the treatments to be conducted in a safe but also equitable manner. Training programs so that we can address workforce needs in all countries and regions. And also the importance of research and generating evidence for the use of theranostics so that we can therefore have justification for their funding at a country level. In our commission, we also assessed the research priorities and the impact of digital sciences, and three main priorities were identified. Firstly, that we should be increasing clinical trials, and particularly for common cancer types in low and middle income countries. This may require connectivity and collaborations with high income countries. To scale up quality improvement and implementation research, electronic medical records and digital analysis and AI support clearly have a major role. And also to develop clinical practice guidelines based on clinical trial evidence, both in high and in low and middle income countries. So in conclusion, the coordination of resources for radiotherapy and theranostics delivery are key. Global standards are necessary. We've identified, and this was also shown in the problems of access and availability of radioisotopes during COVID, that supply chains are critical. We support increasing the number of clinical trials for evidence of use and to improve the regulatory infrastructure for theranostics. And of course, innovative financial solutions and collaborations between sites and countries will be key. Thank you.
Nicely the work of the Commission, not only highlighting the scale and the magnitude of the problem, but also offering very good solutions and opportunities that exist for addressing the problems that you've identified. As I look at your slides and I look at those maps, one thing that strikes me is the gray areas of no data. And I think we all should work on the fact that data should no longer be thought of as a luxury or an option, but should be think of as an asset that one should grow and manage. But with that, I think it's very important to look at the perspectives of other organizations on the findings of this commission and what it means to them. And with that, I'd like to introduce Mauro Carrera and Diana Paez-Gutierrez to take us to introduce the shared perspective on the impact of the Commission. Thank you.
Thank you so much, Mary. I will start with the introduction of the panel, and it is a privilege for me to welcome you to the panel discussion on chair's perspectives on the impact of the radiotherapy and theranostics in Lancet Oncology Commission. This comprehensive report, available online as of 30 September 2024, was created to assess the access and availability of radiotherapy today, and to address the important issues of access to the promising field of theranostics at a global level. It outlines specific recommendations for policymakers, healthcare providers, and international organizations to bridge the gap in access and ensure that the availability of radiotherapy and theranostics are realized worldwide. One of the key messages of the report is the urgent need for increased investment and strategic actions to expand access to these technologies, especially in low and middle-income countries. Today, our esteemed panelist, Dr. Jeff Mahalski, former president and chair of the board of the American Society of Radiation Oncology, Dr. Lancet Liu, president of the World Federation of Nuclear Medicine and Biology, and Dr. Jean-Luc Orban, president-elect of the Society of Nuclear Medicine and Molecular Imaging, will delve into the findings of this report and discuss its implications for global health policy and the challenges of implementation. We will explore how these recommendations can be translated into actionable strategies to enhance patient care and reduce the global burden of cancer. Thank you for joining us, and I look forward to a stimulating and insightful discussion. Over to you for the presentations.
I'm Jeff Mahalski, former president and chair of the board of the American Society of Radiation Oncology. I want to extend my congratulations to May Abdelwahab and Andrew Scott on the publication of the update to the 2015 Lancet Commission on Radiotherapy and Theranostics. Cancer is a global problem with nearly 20 million new cancer cases diagnosed each year. In 2015, this commission highlighted disparities in outcomes across the globe. While the risk of cancer deaths and disability have been reduced in developed countries, there were glaring deficiencies in cancer care in low and middle-income countries. One remarkable inequality was the lack of sufficient radiation therapy facilities to meet the needs of growing cancer patients in these countries. Over the past decade, there has been some progress, but considerable gaps remain. As was emphasized in this report, there is an urgent need to expand education and training of personnel to execute safe and effective radiation therapy. Universities, medical schools, and health service training programs need to invest and prioritize the education of medical professionals that include not only physicians, but ancillary professions such as medical physicists, therapists, nurses, and dosimetrists. To achieve this goal, the ministries of health and ministries of education need to partner with these academic centers to attract, recruit, and retain students who are interested in careers in healthcare. Great strides in artificial intelligence and remote learning have helped bridge the knowledge gaps to facilitate high-quality care to remote communities. Continued research and investment will help assure that high-quality care is maintained and remains local. I was excited to see that the growing field of theranostics was included in this updated report. Recent developments in radioactive drugs have made substantial improvements to quality of life with extended survival with patients who have advanced or refractory prostate cancer or other late-stage cancers. We anticipate that there will be more breakthroughs with these radiopharmaceuticals to treat more types of cancers. As this discovery research takes place, it will be important to simultaneously establish means to manufacture and deliver these drugs predictably, reliably, and safely to the hundreds of thousands of patients who may benefit from them. On a very positive note, over this past decade, we've witnessed clinical trials and subsequent rapid adoption of more efficient schedules of radiation through hypofractionation. These shorter courses of radiation therapy save costs and resources and make radiation therapy feasible for many patients in need of these life-saving treatments while simultaneously saving billions of dollars. So again, congratulations to the Lancet Commission on shining a light on these global needs in radiation therapy services, reporting on the considerable progress that has been made to date, and highlighting the persistent needs for education, training, and investment in global radiation oncology programs.
I am Dr. Lizette Lowe, a nuclear physician and president of the World Federation of Nuclear Medicine and Molecular Biology. Although we already knew there is a discrepancy in theranostic access between areas with limited resources compared to areas with lesser limitations, the Lancet Oncology Commission report managed to confirm this in a factual and qualitative manner with numbers and statistics. Understandably, one cannot initiate change based on a gut feeling and assumptions. This is one of the many reasons why the Lancet Oncology Commission report is so important. With this report, global entities such as the World Health Organization and the International Atomic Energy Agency can be approached to facilitate a change in healthcare policies on international or even national and regional levels. Many low and middle income countries rely on policies and input from global organizations such as the WHO to develop, expand, and improve their own healthcare policies. By providing factual evidence from the Lancet Oncology Commission report, real change can be pursued to improve equitable access to theranostics. Raising awareness of the lack of access to theranostics will trigger an awareness of the need for adequately trained workforce within these countries. This domino effect will lead to planned and appropriate training of healthcare workers to achieve a minimum required standard in order to provide quality patient care. On behalf of the World Federation of Nuclear Medicine, I thank and applaud the Lancet Oncology Commission for the valuable work that they do, which enables real change to achieve our shared goal for equitable access to cancer care, and specifically theranostics. Thank you.
Hello everyone, my name is Jean-Luc Urbain. I've had the privilege of practicing nuclear medicine for 4 decades in Europe, Canada, and the United States. Throughout my journey, I've also held national and international leadership positions in prominent nuclear medicine societies. My perspective on the Lancet Oncology Commission on theranostics are shaped by this comprehensive, multinational patient care experience and a global leadership background reflecting a holistic view rather than the view of any single society. By convening a multidisciplinary team of medical, basic science, and policymaker experts, the Lancet report has effectively documented and raised awareness about the existing inequities and disparities in access to these important therapies for cancer patients worldwide. By focusing on equitable access, healthcare providers have now a powerful advocacy tool to emphasize the urgency of integrating theranostic treatment more widely for the benefit of all patients, regardless of geographic or socioeconomic status, and also to advocate for comprehensive healthcare policy changes. To address the current significant and global shortage of educated and qualified personnel required to administer therapeutic radiopharmaceuticals, we can now advocate for specialized educational and training initiatives to build a skilled workforce capable of supporting the growing demand for theranostics. By developing and implementing standardized protocol and guidelines for the administration of theranostic treatment, we should also be able to minimize variability in clinical practices and enhance the efficiency, safety, and effectiveness of these therapies. Increased investment in research and development of new radiopharmaceutical and theranostic techniques will help providers expand treatment options for cancer patients. Addressing existing barriers to clinical trials and regulatory approvals, and emphasizing the need to facilitate the transition from research to clinical use will help patients benefit faster from the latest advancement in theranostics. By enhancing physical and technological infrastructure for theranostics, we should be able to make this advanced treatment more broadly available, particularly in regions where there are significant gaps in theranostic capabilities. Addressing financial barriers, promoting sustainable funding model, and advocating for favorable reimbursement policies should also help with the access to these therapies and the long-term viability of theranostic services. With the explosion of medical and scientific knowledge and technological advances, integration of a theranostic professional is essential for optimizing patient outcome and for leading to a more comprehensive and effective patient care. In my view, the Lancet Oncology Commission report on theranostics represents a landmark achievement in advancing the provision of cutting-edge nuclear medicine therapies to benefit all cancer patients, regardless of their geographical or socioeconomic circumstances. Overall, this report has the potential to serve as a catalyst for a comprehensive roadmap aligning the effort of healthcare systems, researchers, policymakers, and medical professionals towards accelerating the global adoptions and availability of theranostics, and ultimately improving patient outcome and transforming patient care. Thank you very much.
So thank you for watching this recorded session on the impact of the Lancet Oncology Commission on radiotherapy and theranostics. We extend our gratitude to Dr. Jeff Michalski, Dr. Lancet Lowe, and Dr. Jean-Luc Urban for their enlightening contributions. Many key messages were highlighted by the panel, including the fact that despite some progresses, global inequalities in access to cancer therapies, including access to radioactive drugs for theranostics, remain significant. Education and training must be prioritized for multidisciplinary teams of healthcare professionals to address the current significant shortage of qualified professionals and personnel. The importance of this report as a powerful advocacy tool is also highlighted. Factual evidence, such as the one provided by the Lancet Oncology Commission, is essential to address the highlighted disparities and bridge the gap in access, drive changes in healthcare policies, enhance investments in research, education and training, and strengthen collaboration among international and professional organizations. Regardless of geographic or socioeconomic status. So thank you again. And as my colleague Diana said, we are looking forward to a stimulating and insightful discussion. By that, I hand back to the moderators. Thank you.
I think the next part is the implementation of commission fundings.
Yes, hello everybody, and thank you for being here. Welcome to this second panel discussion on the implementation of the findings from the Radiotherapy and Theranostic Lancet Oncology Commission. As previously discussed, this report outlined essential recommendations for stakeholders to tackle the inequalities in access to radiotherapy and theranostic, aiming to make these benefits accessible globally. Moreover, the report emphasized the critical importance of boosting investment and implementing strategic measures to enhance the availability of these technologies, particularly in low and middle income countries. To discuss this, we are privileged to have as esteemed panel of experts, including two radiation oncologists, Professor Jolande Leuvens, President of the European Society of Radiation and Oncology, and Dr. Sortati Gondviarcio, President of the Federation of Asians Organization for Radiation Oncology. We have also one patient representative, Mr. Josh Mailman, President of NorCal Carcinet Community, and one medical physicist, Professor Will Ngwa, Director of the NGO Global Health Catalyst. Despite the rise in global incidence of cancer, there is still a considerable variation in equipment, human resources, and access between wealthier and less resourced nations. Our speakers will address these issues and discuss how the report's recommendation can be implemented in a way that drives global health policy change. We will explore how to turn this recommendation into actionable strategies to improve patient care and reduce the worldwide cancer burden. Dear panelists, the floor is yours.
Hello, my name is Jolande Leuvens, a professor in radiation oncology at Ghent University, and I'm happy to share some highlights from this recently published Lancet Oncology Commission report on radiotherapy and theranostics, representing the European Society for Radiotherapy and Oncology. The question on how to optimize radiotherapy access is still highly relevant. The report clearly shows that even today, there's an extremely high variability in availability of both human resources and equipment, both fundamental to a certain radiotherapy access, not in the least as cancer incidence is continuously rising, creating parallel increasing demands for radiotherapy services. I've chosen to highlight a few possible approaches discussed in this Lancet Oncology Commission report that are also evaluated through ESTRO programs, such as the HERO project, and which, if correctly addressed, could help closing the access gap. Hypofractionation has been proven to provide equivalent clinical outcomes as conventional radiotherapy, for example, in frequent cancer types as breast and prostate cancer. The reduced total treatment time can translate in different benefits from a healthcare perspective. One is lower treatment costs, provided that the liberated resource time is used to treat additional patients, which is typically the case in low and middle income countries where resources are limited. The report indeed demonstrated that broadly deploying hypofractionation would allow to treat millions of additional cancer patients with the same resources worldwide. Regardless of the clinical benefits and the possibility to overcome limitations in resources, we know that hypofractionation remains unequally implemented. Evidence as the one presented should therefore be used to inform policymakers to address health system hurdles that might hamper implementation, such as reimbursement schemes with negative incentives towards its use. As stated in the report, the development of more efficient funding of radiotherapy services and inclusion of radiotherapy into universal healthcare coverage schemes is imperative to make radiotherapy broadly accessible. Operational aspects at the departmental level should also be considered to optimize availability and access. Extending operational hours, for example, is a strategy that would allow increased patient throughput without the need for additional capital investment, which may be beneficial, especially if labor costs are low in comparison to capital investment costs. But this then puts additional burden on the workforce that is already under high pressure. Which brings me to a last interesting approach, the integration of artificial intelligence into radiotherapy practice, which can indeed lessen the burden of routine tasks on the workforce. It may, however, also introduce new challenges and risks. Radiotherapy professionals must therefore be educated and trained to use and maintain these systems, and any AI-based tool should be proven safe, effective, appropriate, and efficient before clinical adoption. I think this report clearly shows that addressing a global problem as suboptimal access to radiotherapy requires solutions at different levels and should link implementation of clinical evidence with operational optimizations and actions at the health system level. Solutions should moreover be underpinned by evidence from clinical and health services research. I'm convinced that only by doing so we can step by step decrease the access gap to radiotherapy and bring the best value for our patients and for our societies. This Lancet Oncology Commission report is a strong asset in this endeavor. I thank you for your attention.
Hello, I'm Sotati Gondowiarjo, radiation oncologist from Indonesia, and I'm honored to contribute to this vital discussion on radiotherapy access in low and middle-income countries, as outlined in this Lancet Oncology Commission report. First, it's essential to emphasize that expanding radiotherapy access in LMIC required a multi-sectoral strategy. A key approach is strengthening National Cancer Control Plan, integrating radiotherapy into this plan, and ensuring government commit to long-term investment. This involves advocating for radiotherapy as an essential part of the universal health coverage agenda, making it a priority in health policy discussion. To ensure more efficient use of radiotherapy machines, the Commission recommendations stress the importance of optimizing workflow. This could include a centralized planning for machine placement in the region with the highest patient load and using telemedicine for treatment planning and consultation. Furthermore, adopting hypofractionation, delivering fewer but higher doses of radiation could reduce a machine burden and allow more patients to be treated within the same time frame. But this needs to be done cautiously with proper standard and routine auditing procedures to ensure radiation safety. Further issues is addressing the critical workforce gap. To enhance training and increase workforce number, we need to focus on developing regional training centers that can provide continuous education and certification program for radiation oncologists, physics, as well as therapists. Partnership with a goal institution can facilitate mentorship and exchange program, while e-learning platform can improve access to update knowledge and skill. This strategy not only train more professionals, but ensure that they stay at the frontier of radiotherapy advancement. To ensure quality and access of cutting-edge technology, international collaboration are key. Public-private partnership can help facilitate access to modern radiotherapy machine, and organizations like an International Atomic Energy Agency, or IAEA, can support regulatory framework and safety standard. Another crucial step is investing in technologies that are adaptable to the infrastructures of LMIC, such as a compact energy efficient machine and software platform that simplify treatment planning and delivery. In summary, achieving the action laid out by the Commission required integrating radiotherapy into National Cancer Plan, optimizing the use of existing machines, bolstering workforce training, and forging international partnership to improve access to quality care. By implementing these strategies, we can significantly improve cancer outcome in LMIC and ensure more equitable access to life-saving radiotherapy treatment. Thank you.
Good afternoon, good morning, or good evening, depending on where you're watching this. I'm Josh Mailman. I'm president of NorCal Carcinet Community. I am also a patient who has undergone radiotherapy and theranostics over the course of my 17 years in dealing with a neuroendocrine tumor. I've been fortunate to travel the world and talk to people, talk to patients, talk to healthcare providers about radiotherapy and theranostics. I'm delighted that the Lancet Oncology Commission on Radiotherapy and Theranostics invited me to do this short 4-minute presentation about what I thought about the article and things that we can learn from it. So let's dig in. What are the key findings that we saw in this that relate to patients and patients advocates? So when I look at this, there are several things that concern me. This is a look at one of the charts inside of the article and where the distribution of radiotherapies and theranostics are. And you can see highly concentrated in developed countries or high-income countries, and much less available in other areas of the world. This is not helpful for access and equity to patients outside of the countries that are in green, and it causes patient concerns to patients who now are connected globally and can see and understand how other patients are being treated around the world, creating even more inequities. I bring this slide up. This is a slide on where we have radiotherapy and this is Linacs in Africa. And while it is really scarce, the other challenge besides it being scarce is it's being unavailable for maintenance or other reasons. If you look at the downtime available for these types of machineries in the developed or high income countries, it's, you know, in the small single percentages, where if you look at where we have them in Africa, we see large amounts of downtime. And I think one of the beauties of radiotherapy and nuclear medicine is these are very durable treatments, because some of the challenges in these countries that are lower income is both, as you can see, the availability of these machineries, of these machines, and the access to it actually working on time. Patients will travel a great distance, and you may only get to see them once or twice a year or 3 times a year. And if the machinery is not available due to maintenance or not having parts or contracts, you will see patients who are not able to get therapy. So one of the other questions that was asked is what approaches could be used to improve the knowledge of radiotherapies for patients and the public? And I think, you know, part of it is, as this is a global recording and really a global discussion, is we need to listen inside of each country to see what the challenges of delivery are. We need to educate both patients, healthcare providers, hospitals, regulatory and government officials on the benefit of radiotherapy and theranostics. And lastly, so we need to educate and we need to involve, and I'll talk to that a little bit more, patient advocacy groups, because a lot of what we're looking at, and this is a chart of some of the action steps that were recommended, are short and long-term goals. And without all the providers or all the players involved in each country, we're not going to be able to move the needle very far. So how can patient and advocacy groups impact improved access? Well, involve us, talk to us, educate us on what's at stake so that we can be a voice alongside our nuclear medicine counterparts to help bring change either at the regulatory or the governmental agency. Besides involving us, make sure we're understanding what we're getting involved in, because that will make us much more effective advocates for nuclear medicine, radiotherapy, and theranostics. And with that, I'd like to thank you for listening to this brief overview of what I thought of the article and how I think we can participate. And thank you for your time.
Hello. I would like to thank the Lancet for inviting me to participate in this webinar for the Lancet Oncology Commission on radiotherapy and theranostics. This is really an excellent report, and I would like to invite everybody to get to read the report itself in detail. But today I will talk about implementation approaches to achieve improved access to radiotherapy and theranostics for patients. Just stepping back a little bit, if you look at the current reports on cancer incidence, you really see the importance of this commission report. The World Health Organization predicts that by 2050, we'll have about 35 million new cases a year of cancer. And this is really a difficult situation where I think we really have to agree with the commission report that we must collaborate to change this narrative. And as you think about this rise in incidence on cancer, it's not just that. As you see from this figure from the commission report, there are major disparities in access to treatments like radiotherapy. You can see that from this map. South America, Southeast Asia, and Africa, there's just very little access to radiotherapy. And in particular, I just want to give an example. Cameroon, where I was born, a country of 30 million, currently they only have one radiotherapy center. And that really means to serve a country of 30 million people with one radiotherapy center, this is really just not acceptable. In fact, it's tragic. So what are some of the key ways that we could address these disparities and increase access to care coming out of this commission report? There are three approaches that I really want to highlight, and these are three things that I'm actually very actively involved in. So one is the fact that hypofractionated radiotherapy can substantially increase access. So just to give you an example, the time it takes to treat one patient with conventional radiotherapy, if you use hypofractionated radiotherapy today, you could treat 5 people, literally, from the predictions that you can see here. And I think that really is a tremendous approach for increasing access to care. As an example, I was recently in Ethiopia where I saw a list of cancer patients who died waiting for radiotherapy. And I thought, if you can use hypofractionated radiotherapy here in this country, you could actually have, had some of these patients not die without having access to radiotherapy. The second thing that I'd like to highlight is support for clinical trials. So currently we are actually conducting what you call hypofractionated radiotherapy clinical trials across Africa. It's called Hypo Africa. And so we're doing this for prostate, for breast, and for cervical cancer with support of BioVentures for Global Health. And what we've really seen through these clinical trials is that it's now gone to not only generating the evidence for being able to use hypofractionation for this particular patient population, but also helping build the capacity of the doctors, the oncology health professionals. And then last one thing that I want to highlight is the need for innovative financial solutions. And so we've been working really hard with the White House to establish what you call a global cancer fund that can help support maybe infrastructure like radiotherapy, or workforce development, or even the elimination of cervical cancer. So this is really an exciting example of innovative financial solutions that we must consider as we think about addressing this. Thank you so much for your attention.
So I think it's again me. I wanted to say that the panelists emphasize that over half of cancer patients worldwide require radiotherapy for effective treatment. However, the availability of radiotherapy machine and trained personnel is severely limited, especially in low and middle income countries. And theranostics offer precise tumor targeted, but faces similar accessibility challenges. To address these issues, the panelists call for the substantial investment in infrastructure, workforce, training, and regulatory support. Advances in radiotherapy techniques, such as hypofractionation or artificial intelligence, can increase treatment capacity, but specialized education remain essential. Barriers to theranostics include supply chain, issues for radiopharmaceuticals, regulatory hurdles, and workforce shortages. Expanding research, developing new theranostic agents, and reforming regulation are necessary steps, along with improving medical imaging for both radiotherapy and theranostic. Financial constraints, including insufficient fundings and reimbursement issues, further hinder access. Addressing these financial and regulatory challenges and establishing standardized protocols can enhance patient care and improve equitable access to the advanced therapies. In conclusion, the Lancet Oncology Commission emphasized that the urgent needs for global action to bridge the gap in access to radiotherapy and theranostics, particularly in low and middle income countries. By tackling workforce shortage, regulatory barriers, and financial constraints, we can improve the availability of these critical cancer treatments. Investing in infrastructure, training, research, and technology will help deliver these life-saving treatments more broadly ultimately reducing the global cancer burden and improving patient outcomes worldwide. Thank you for your attention.
Thank you very much. So we now have about 20 minutes for a Q&A. So I would like to invite the people who are attending online to post the questions in the chat. As I was listening to the full set of presentations, I sort of was wondering, the recommendations say what should be done, but not necessarily who is going to do it. And I thought that maybe I would invite May Abdel Wahab to maybe comment a little bit what's already being done by IAEA to address the situation, and how, in her perceptions, can the community, global community, help to advance the actions that, for example, IAEA is taken, and then we can discuss the actions that maybe professional societies should be taking, and I'll take it to Andrew and the others. So May, over to you.
Thank you very much, Mary. So yes, who does what? If we all depend on each other, another person to do it, nothing gets done. So the answer is it has to be a collaborative effort where it takes a village. So we have our policymakers, we have to have ones that are really interested in supporting and moving policy forward. We have international organizations that are responsible for many things. I can give examples of the IAEA, where for the education and training part, we're doing our part and working to see how we can get certification, supporting groups on the ground that are working on this area for, let's say, medical physics or others. We're also supporting setting up centers on the ground. Again, in different countries, the Rays of Hope initiative is a very good example of that, where we are helping countries sometimes for the first time developing their radiotherapy centers in Africa, and at the same time improving radiotherapy services elsewhere, supporting anchor centers and developing more robust educational activities. But then the two additional parts, other than the routine, are the innovation part, which is extremely important, innovation education, and in research. So hypofractionation studies, for example, we do that, and we've done that for a few years now. GBM, head and neck, to lower the number of fractions needed. And also innovation education, where we want to see if we can provide tools, online, virtual reality immersion, things like that, that help make the training process a bit more effective. So all of these things are being done. Having said that, we have our NGOs that are very active on the ground. There are many examples of these NGOs, whether URCC, CCAN, I mean, I don't want to leave anyone out because there's so many in radiotherapy. There's a few that are specifically like Radiating Hope and others. And then, of course, I think I mentioned UIC, and we have Global Catalyst that's active, many others. Then we get to the next thing, which is the professional societies. And those are such an important force because you have a large group of experts in the area that are specifically dedicating their whole lives to moving the clinical parts forward in many cases. And those would provide guidance, would provide expertise, would help also advocate from the policy level. And then, of course, money is always important. So funding organizations also working together. And all of these groups, including private industry for public-private partnerships, can work together. So bringing everyone on one platform, and it's a labor of love because it takes time to get everybody to on the same page. But then once you're there, people move forward together, and that's been our experience, at least at the IAEA.
Can you talk a little bit more about Rays of Hope and the concept of networking and the the centers that will help you implement the programs?
Well, thank you very much. So yes, Rays of Hope is an initiative that the IAEA DG Grossi, who is very supportive in terms of the cancer, addressing cancer worldwide, has initiated back in the African Union, or launched an African Union meeting, summit meeting, about two and a half years ago during World Cancer Day or week. And since then, we've had 3 pillars. One is setting up centers on the ground, and that's self-explanatory, whether it's long-term training of newly minted professionals, or whether it's buying equipment and setting it and that. And that's why many of the people around the table are colleagues, whether from medical physics and nuclear medicine, radiation oncology, that provide expertise, and also the global community with professional groups and others. We have experts from every country that have really contributed. Then we have the next step. The second pillar is the anchor centers, which I'll discuss. And the third is research and innovation. And that we have a Sunrise initiative that will be collecting global radiotherapy data and radiology and a lot of data, so to speak, including health economics data that will be very helpful for policy and so forth. The anchor centers, the second pillar that you asked about, Mary, is basically looking at centers of excellence that have been training people in the region and supporting the region for a long time. And the idea is to support them as well in terms of QA and education and other things, and create a network of these centers of excellence that will support each other, but also support the region. And the purpose of that is for sustainability. These centers go through a very extensive process of evaluation across the board in all the different aspects. And we can talk about that if someone's interested another time. But basically, they are really the leaders in the region that have already been supporting the region for a long time. And now we're taking it to the next level. And they are coming together to create this network that supports each other and supports the regions with research, quality assurance, the whole 9 yards. And of course, training, long-term training. So this is an idea that really will promote the sustainability of this initiative long after the initiative is done. By the way, we have 85 countries that have now requested to be part of Rays of Hope and supported by Rays of Hope. And we finished our first wave in Africa that are already, they've gotten funded, and many of them have already, like in Niger, the LINAC was the center was launched. There was a ceremony for that, and many other things that are happening around the world that are really exciting for us. So the anchor centers, we have 10 so far, but we have a couple that have already been approved and gone through the whole long process of approval. And then and we have several that have applied and we're looking at. So they're good citizens. It takes good citizens, whether at the professional level, at the country level, at the institutional level. We have to just work together and things fall into place.
Thank you, May. I found the presentation by the patient representative very exciting. I have to tell you, the way that Canada secured access to radiotheranostics for neuroendocrine tumors was purely because of patient advocacy. So Cheryl, I was wondering whether you can sort of ask some questions about access to radiotheranostics, radioisotopes, and let's put Andrew and Francesco and Mauro and Diana a little bit on the spot.
Thank you, Mary. Yeah, so just switching tack a little bit. So the global supply chain of radioisotopes is certainly an important factor in ensuring equity in access to theranostics around the world. How can we build resilience in the supply chain to sustain and protect reserves of radioisotopes?
Andrew, you want to take this one?
Thanks very much. Yes, thank you. So I think that there's a couple of areas that we can pursue in order to be able to address this point. The first is that strategic planning for reactors and cyclotron-produced radioisotopes is necessary. There's an increasing focus on sovereign capability, and I think that's very important to ensure that governments are aware of the requirements for supply chains. And this can occur both at a country and a regional level. I think that IEA and WHO can play an development strategy, and also industry plays a very important role. That can be both through engagement of professional organisations with industry, and also through some of the high-level discussions through the Nuclear Energy Association as well. And finally, I think some of the newer technologies may assist with using both lutetium and some of the other particle radioisotopes as well.
If I may pitch in on this one, actually, Andrew highlighted some of the very important issues or challenges that we have in access to theranostics. Definitely, the global supply of radiopharmaceutical is hampered by a multitude of challenges, spanning the production. As he mentioned, there is a very limited production, and it will not suffice to cover the projected needs. The supply chain logistics that was mentioned by Dr. May Abdel Wahab at the beginning, and during the COVID, we saw how one of the main medical imaging studies that were affected were the nuclear medicine, not only the SPEC, but also the PET. The cost and the reimbursement. Unfortunately, the cost of the therapies is quite high. And again, we face the problem that it is only available for the people that have some wealth to be able to cover. Research and development. A handful of countries and a handful of groups doing this around research and development. We need more. Safety and quality, education and training. So there are many things, many building blocks that we have to put together in order to be able to have access to theranostics. What can we do? We have been doing many things. In the IAEA, we work in every single aspect, supporting the production up to the access to care, to technology transfer, to capacity building. But more importantly, we have been working with several professional organizations. And testament of this is all the people that have participated in this wonderful London Global Cancer Week, launching the Lancet Oncology Commission on Theranostics and Radiotherapy, European Association, Societies of Nuclear Medicine, Radiology, Radiation Oncology, and many other groups. So this is, I think, the main idea is to join forces, work together, do not work in silos, and tackle all the different challenges that we need to face in order to be able to have better access to theranostics. Thank you so much. Cheryl?
For low and middle income countries. And I was wondering whether May can address that, because I think that certainly in our previous commission, we talked about potential of collaboration and pooled procurement, but I wondered whether May, you want to address the issue of negotiating prices.
That's a kind of sensitive issue, of course, and there are differences for many reasons in prices, but there are many opportunities. I know that we have like special agreements and bulk purchases and things like that. And maybe Mauro can give an example. But we also have, we're thinking of things like reimbursement based on time that the machine is up, for example. So a completely different way of addressing these machines to make them more efficient. So a lot of times when people buy them and they keep breaking down, so one way to do it is to tie reimbursement or costing to whether the machines are working, and maybe some type of leasing agreement, and this kind of thing. So those kinds of arrangements are being discussed, and whether or not this results in a positive outcome is to be seen. But alternative approaches, And then again, we have at the IA, at least we have special kind of agreements that allow us to make the procurement process a bit easier. I think those are the main things.
Yeah. Thank you for that. I mean, I think it goes to what you said before about collaboration. So in Canada, in our province, we do pooled procurement for equipment. There was a very interesting paper from India, from National Cancer Grid, where they did pooled procurement for drugs. They published it in WHO Bulletin, showing that when they got together and small centers combined their demand for drugs and were able to order in huge volumes, they were able to lower the cost of drugs up to 80%. So I think the pooled procurement is a concept that could be developed, especially in smaller countries that will buy small number of equipment where sort of one-off costs are high. So that has goes together with your very strong recommendation for collaboration and coordination in the Commission. And I think we can improve the access to everything through that. I don't know whether anybody else would like to comment.
Yes, I have a comment on this. I think it's fundamental. You're perfectly right, and maybe IA can have also a role in this global procurement. The problem is in cases where there is no competition, because unfortunately in nuclear medicine theranostic, we have products that are produced by only one company. And in this case, I don't think that the difference will be so evident. So the idea is to promote the different alternative production of radioisotope in order to be able to increase the offer, and also to, if when possible, but this maybe Mauro will be better than me in saying this, but when possible to produce this radioisotope in the same hospital, and in this case the prices will lower. Of course, there are specific legislation. We have two kinds of legislation: is the pharmacy legislation and the radiation safety legislation. So we have also to deal with this. And this is also a role of IAEA in order to simplify this aspect in those centers and to lower the cost of the treatment. This is my opinion. Thank you.
Thank you, Cheryl.
Okay.
So we also have a short message from Professor Rudi Dierix, who is president of the European Association of Nuclear Medicine. He just provided some few comments to congratulate the Lancet Oncology Commission on its pivotal work. The EANM recognises several of the bottlenecks discussed and wanted to stress some highlights and related actions, and these are related to supply chain stability, workforce training. Global training standards are very important, and as part of that, the EANM has established the Inspire project for young people who have still not decided, students who have not decided on the career path. He also provides some thoughts on infrastructure strengthening, especially in low resource areas, including the accreditation of centres of excellence and accreditation of related imaging or support for AI initiatives. And the EANM also recognises the importance of regional production centres using, for example, cyclotrons, and the involvement of peripheral hospitals in regional settings for quality care, and as advocated by ECHO in Europe. For a patient-centered approach. So thank you for Professor Rudi Dierix for providing some additional comments. I think with that, we're almost out of time, so I think we'll have to leave the Q&A session here. I want to thank everyone who's participated and contributed to this webinar. Thank you to all of the authors of the Commission, the speakers, and the society and organisational representatives for their contributions, and to all those who are listening, and to those who contributed a question, and to the organisers of London Global Cancer Week for including this webinar in the week's events. I'd also like to thank my colleagues Max Peters and Sophie Cox for their work in producing this Lancet webinar. Just a reminder, you can read the Commission report on thelancet.com. The report's been made free to access with registration during London Global Cancer Week and is free until the end of November. And the on-demand version of this webinar will be sent out after this session has ended. I hope you enjoy the rest of London Global Cancer Week, and thank you so much for joining us for this webinar. Goodbye.